Hello and welcome to today's presentation, a live broadcast of Tales from the Clinic, presented by the American Society of Human Genetics, LabRoots, and our clinical genetics team here at the University of Washington Medical Center. We're excited to have this educational virtual meeting for you all today. My name's Lauren. I'll be your moderator for today's event. We hope to make this event as interactive as possible. Please use the green Q&A button to the bottom left of your screen. We've prepared several slides and several cases to go through with you in hopes they will be relevant, especially to those practicing in primary care. Feel free to submit questions that are related to some of the cases that we've prepared, but also related to things that you've seen in clinic that you think would be relevant to a broad audience. We'd be happy to be fielding those questions both during our presentation, their presentation, and afterwards. We have some time allotted for questions, and we'll try to get through as many as possible. But right now, I'd like to hand it over to our three speakers today. We have Dr. Fuki Hisama, Dr. Eric Konnick, and Miss Laura Amendola. One other housekeeping item is that before we get to the end of the presentation, there's an opportunity for free continuing education credit. So make sure you stick around and we can walk you through what those steps are to obtain those credits at the end. But for now, I'd like to hand it over to our speakers.
Hello and welcome to the Tales from the Clinic broadcast from the University of Washington. My name is Dr. Fuki Hisama and I'm the clinic director of the Adult Genetics Clinic here. By way of introduction, I just want to explain for a minute, for those of you who aren't aware of the role of a clinical geneticist. Dr. Konnick will describe the role of a lab geneticist, and Laura Amendola will discuss the role of a genetic counselor. After that, we'll launch right into the cases. So a clinical geneticist is a physician who does graduate medical education, residency training in the field of clinical genetics. So I am board certified in clinical genetics and have over 20 years of experience in the field. So as a physician who specializes in genetics, I see patients in my clinic who have themselves a genetic condition or have a family history of a genetic condition. And I and my colleagues diagnose, evaluate, and manage these patients. Okay.
Hi, I'm Dr. Eric Konnick, and I'm a laboratory geneticist. So I'm a physician, and I've gone through postgraduate education in pathology and laboratory medicine, as well as molecular genetic pathology. And so our role in the laboratory is to take the scientific literature, take the medical needs, develop new laboratory procedures, and make those available to patients and physicians to help in the diagnostic process.
Hi, I'm Laura Amendola. I'm a genetic counselor. Genetic counselors have specialized master's degrees, and we work in a variety of settings in research, in the laboratory, as well as in the clinic. Our patient population is similar to the medical geneticists, so patients and families who either have or are at risk to have a genetic condition. And we work with patients to talk about genetic testing options, help them make informed decisions, and then interpret the clinical significance of genetic test results and provide psychosocial support throughout that process.
Okay. So you may be aware that in genetics clinics, some of them specialize in prenatal conditions, pediatric genetics, or adult genetics. In our clinic here, we specialize in primarily seeing adult patients. And so we thought that we'd present some recent cases from our clinic for you. And again, you're welcome to ask questions during the presentation. So the first case is coming for a family history of breast cancer. And the patient is a 25-year-old woman who went to see her primary care provider for a wart on her index finger. And she said, by the way, she's also concerned about her family history of cancer. So her primary care physician asked some questions and then referred her to the University of Washington Adult Genetics Clinic for consultation. So what kind of a family history might one elicit in this kind of a situation? So here is a sample pedigree, and here is the proband indicated by an arrow. Here is her mother and her father. And so here we have a situation where each grandmother had breast cancer, but after menopause, so diagnosed at age 65 in the maternal grandmother and at age 73 in the paternal grandmother. We also know that breast cancer is quite common in the general population. 1 in 8 women will develop breast cancer. So it's not unusual to have a family history of 1 or even 2 female relatives having breast cancer at an older age. In this situation, also notice that, of course, it's a grandmother on each side of the family, so they're not genetically related to each other. So this is what I would consider to be a non-concerning family history that's more typical of sporadic breast cancer and not highly suggestive of a genetic etiology. Whereas this particular patient's breast cancer family history of breast cancer was more like this. So this is the patient, again, the proband who presented for consultation, and her mother actually died of breast cancer in her 30s. I'm sorry, of ovarian cancer in her 30s. A maternal aunt died of breast cancer at age 41, and then the maternal grandmother, great-grandmother, and also these great aunts all had breast cancer at young ages. So this is a very concerning family history of breast cancer for the following reasons. First of all, we see breast cancer in several generations. So it looks as though something is being transmitted through the family. Additionally, the breast cancer is predominantly happening at younger ages, which is, again, a clue to a potential genetic cause for the breast cancer in this family. And finally, there's the combination of breast and ovarian cancer, which raises concern for hereditary cancer risk more than just a history of breast cancer alone. Finally, I will also mention that this woman's mother, because of her striking family history of breast cancer, actually underwent preventive mastectomy to try to prevent the breast cancer based on her family history, and unfortunately subsequently developed ovarian cancer, which she did not know was also associated, that she was at increased risk for. So what does happen after the patient is referred to our clinic? So before the visit, we spend time actually obtaining and reviewing records on the patient if she herself has had cancer, and also medical records on relevant, that is, affected family members who've also had cancer. We think that's very important to establish the accuracy of the diagnoses, which may be reported or misunderstood by the patient herself. At the actual visit, we take a thorough medical and family history and draw a pedigree, such as I've just shown you, do a targeted physical exam for physical features that could be suggestive of rare inherited causes of breast cancer, and we provide what we call pre-test genetic counseling about the risks, benefits, possible outcomes of genetic testing. We cover whether the testing is likely to be covered by insurance, the implications for the individual's own medical care, and also the implications of genetic test results for her family members. So in this particular case, this patient, because this was a few years ago, underwent specific genetic testing of the BRCA1 and BRCA2 genes, and she had sequencing and deletion duplication analysis testing. Nowadays, we might consider actually sending, instead of testing limited to those 2 genes, a panel of high-risk breast cancer genes. The results of her testing showed a deletion of a portion, exon 17, of the BRCA1 gene. And so the interpretation of this genetic test result is that it's pathogenic, which means that it would greatly increase her risk to develop breast cancer or ovarian cancer in the future, and is consistent and explains, we think, her family history. So what do we know currently about the risk of breast and ovarian cancer that's associated with mutations in the BRCA genes? So again, these are the strongest genetic risk factors for the development of hereditary breast and ovarian cancer. They've been very well studied over the past 10 to 15 years, and so a great deal is known actually about the cancer risks associated with these. So we can see that the breast cancer for a woman with a BRCA1 mutation is increased from the population risk of 12% to around 40 to 87%, and the risk of breast cancer with a BRCA2 gene mutation is 28 to 84%. You can also see that compared with the general population risk for any woman to develop ovarian cancer of less than 2%, that also dramatically increases to 27 to 63% in the presence of a BRCA gene mutation. Importantly, men can also inherit and pass on these genes, and there is an elevated risk of breast cancer in men who carry BRCA gene mutations. Breast cancer in men is otherwise quite rare, affecting fewer than 1 in 1,000 men. So the relative risk is substantial, although the absolute risk of between say 1 to 5% is quite small for male breast cancer. And finally, it's also thought that mutations in the BRCA genes increase risk of prostate cancer in men. We also know from longitudinal studies over the past decade that prevention is effective. So in other words, we don't just do testing to tell women that they're at elevated risk for cancer. The testing can be coupled with effective cancer prevention methods. So in other words, if women come to our clinic, they're identified to be at elevated lifetime risk for cancer through genetic testing. Before they develop cancer, they can be offered high-risk screening, such as breast MRI and more frequent mammograms. Chemo prevention is an option for some women to reduce the risk of breast cancer, or they could choose to undergo preventative surgery, such as prophylactic mastectomy or removal of the ovaries and fallopian tubes as a very effective way to prevent developing those cancers in the future. And we know that the surgical methods can reduce the risk of breast and ovarian cancer by 90 to 95%. Okay. So this is another family that I saw in the clinic recently, and so these two sisters came to the genetics clinic, and they're 25 and 27 years old and have not had cancer. Their mother actually was seen in our clinic a few years ago. She's currently age 51, and she at the time had, several years ago, had normal testing of the BRCA1 and 2 genes, including sequencing as well as deletion duplication testing. And she also underwent testing of some additional genes here, MLH1, MSH2, and MSH6, for the separate family history that she had of her father passing away from colon cancer at the age of 50. So our patient's maternal grandmother is living and 78. She had 3 primary cancers, including left-sided breast cancer at 38, right-sided breast cancer at 42, and ovarian cancer at 49. There's some additional family history of a cousin on the paternal side of the family who died of breast cancer very young. Okay. So I'd like to put up a polling question next and see what the audience thinks in terms of what would you do with this family in terms of what would you offer for genetic testing. Okay, so these are the choices. Select the single best answer. A, offer the 27-year-old sister genetic testing for BRCA1 and 2. B, offer both sisters testing with a large panel of breast ovarian cancer risk genes and hereditary colon cancer genes. C, offer updated genetic testing to their mother. Or D, offer genetic testing to the grandmother for breast and ovarian cancer risk genes. So we'll give you about 15 seconds to answer the question, and then we'll see what the audience thinks. Okay, so the top answer here was offer genetic testing to the grandmother for breast ovarian cancer risk genes, and that is the single best answer. That was followed by answer C, which is offer updated genetic testing to the mother. Now I noticed that these numbers are awfully close, however, and so the third best answer was offer both sisters testing with a large panel of breast ovarian cancer risk genes, and few people chose answer A. Okay. So I would say that the best answer, I would agree with the audience, is that the best answer is D, to test the grandmother. The reason is because she is the affected person in the family, and so she is the person who's most likely to have a mutation by testing. The second best answer would be to test the mother for updated genetic testing, since her testing was several years ago. I will also mention that the mother has had colonoscopy and has not had any polyps. Okay. So some take-home points from this case is that overall 5 to 10% of cancers are strongly hereditary or genetic, and clues to an inherited breast ovarian cancer syndrome include age of diagnosis younger than 50 years, multiple primary cancers in an individual patient, the combination of breast and ovarian cancer in a family, or the combination of colon and uterine cancer, as well as cancers in 2 or more generations on one side of the family. And of course, we know that in the Ashkenazi Jewish population, there is about a 1 in 40 chance to be a carrier of 3 common founder mutations in the BRCA1 and 2 genes. It's also important to recognize that the patient who comes to you may not be the most informative person in the family to test, and so genetic testing and evaluation often involves the family. And also, we do think that adequate pre-test as well as post-test genetic counseling are critical to the evaluation.
And Dr. Hisama, I have one question here from one of our attendees relating to the family that you just went over, and maybe you can go back to that pedigree. The question is, for a lot of these folks, the 27-year-old is the patient that's presenting in their clinic, sometimes have limited availability of their other family members to get in and be the one to get tested. And so how reassured would you be for that 27-year-old patient if you were to order that entire gene panel and it was negative?
So that certainly does reduce the risk for her of having an inherited breast cancer condition. However, the problem is, the limitation of that testing is that a normal negative result in someone who's unaffected can never eliminate the risk back to the population risk, because we do not have an explanation for what caused the breast cancer in the family yet, without identifying a mutation in a breast cancer predisposition gene in an affected person.
Mm-hmm. And then another question from an attendee is, and I think it's, if you do testing and it was negative, like in that scenario, or if we choose not to do testing for the time being, what screening are you recommending for those 2 sisters based on the family history they've shared?
So there actually are some risk models that we can use to calculate their lifetime risk, and so typically when the risk is above 20%, then we offer high-risk screening. It's important to recognize also that in addition to testing, that we work with other providers in, for example, the high-risk clinic and other specialized clinics here, so that we can refer them for recommendations regarding screening and prevention. Okay, so I'm going to move on to the second case then, which is an individual who has a family history of sudden cardiac death. So this is a patient who's a previously healthy 16-year-old boy who was playing soccer with his friends who collapsed on the field. They called 911 and he was taken to the emergency department. Unfortunately, he could not be resuscitated and died in the hospital. So this case went to autopsy and showed hypertrophy of the left ventricle of the heart, as well as asymmetry of the interventricular septum. So in terms of what causes sudden cardiac death in healthy young people, there was this review several years ago in the New England Journal of Medicine, which identified cardiomyopathies as the single most common identifiable cause. And of those, hypertrophic cardiomyopathy is the most common. There are also non-structural, typically inherited arrhythmia conditions that can cause sudden unexpected cardiac death, as well as some non-cardiac conditions such as drug abuse, heat stroke, and asthma. Okay. So hypertrophic cardiomyopathy then is the single most common genetic cause of sudden unexpected death in healthy young people. And you may be aware of this because when sometimes in the news, if you hear about an athlete, for example, who collapses on the field, this is typically the cause that is found, not always, of course. And we know that hypertrophic cardiomyopathy is relatively common in the population. There's a prevalence of 1 in 500 people. Hypertrophic cardiomyopathy, we also know is genetically heterogeneous and is caused by mutations in a number of different genes encoding proteins of the sarcomere. And here you can see a normal heart on the left, and here you can see the thickening of the wall and asymmetry of the interventricular septum, which are typical findings in hypertrophic cardiomyopathy on pathology or on imaging. So in this case, a so-called molecular genetic autopsy was able to be obtained, which means that at the autopsy, a tube of blood was saved in an EDTA or purple top tube, and blood spots on filter paper were also saved. So this facilitated genetic testing post-mortem. So then we met his parents in the cardiac genetics clinic here, and genetic testing of 18 genes in a sample from the autopsy showed a likely pathogenic variant in a gene called MYBPC3. So this was a single base substitution resulting in the substitution in a missense substitution, and again the interpretation was likely pathogenic. So this brings up the point that genetic testing is not always positive or negative. Many labs use a 5-tier classification system similar to this. So pathogenic is disease-causing. Likely pathogenic, it's not as strong as pathogenic, but it's thought to be 90% likely to be disease-causing. A variant of uncertain significance is a sequence change or other change in the gene that is detectable, but it's not known to actually cause the disease. Likely benign variation in a gene probably does not cause disease, even though other mutations in that same gene do, and benign variants are not disease-causing and found in the normal population. Okay. So this table is from a paper which is published by Laura Amendola and colleagues, published in Genome Research last year. And the purpose of this table is just to bring out the point that when 6 different labs in the CSER consortium were given the same variant and asked to classify it, they did not always agree. So, for example, this particular variant, all 6 labs agreed that it was pathogenic or disease-causing, and but for other variants, you can see that there was a range of interpretations across the 6 labs, with 4 out of 6 labs here calling this variant a variant of uncertain significance, and 2 of them calling it likely pathogenic. So this is actually one of the active areas of discussion and debate now in the genetics community, is classification of particularly new variants. And of course, in the clinic setting, this is very important as to whether we actually call something that's found on clinical testing disease-causing, or whether it's unrelated to the disease or it's not clear. Okay. In this particular family, the proband had 3 brothers and sisters, and so testing was offered to the family as well as to the parents. It was determined that the likely pathogenic variant found in him was inherited from his mother. She had a normal echocardiogram, so did not have evidence for hypertrophic cardiomyopathy. However, she has 2 nephews who were also tested, have the likely pathogenic variant, and each of them had abnormal echocardiograms consistent with hypertrophic cardiomyopathy. So in other words, further testing in the family gave additional information about what we call segregation, giving additional evidence that this particular variant was the cause of the hypertrophic cardiomyopathy in this family.
Dr. Hisama, I have 2 questions here from 2 of our attendees. One being, is DNA routinely saved following autopsies? And if so, who pays for that testing if we want to use that saved DNA?
Good question. So interestingly, there's not a standard procedure in terms of autopsies, and I've seen differences even from different counties in the state of Washington. So It's not routine or mandated to save DNA from autopsies. I actually visited the King County Medical Examiner's office here to talk to them about the possibility of postmortem genetic testing. And they told me that oftentimes, the results of toxicology take several weeks to come back, and it's really only at that time, if the toxicology is negative, that genetic etiology is considered. And so we talked about ways that maybe it would be possible to save samples for genetic testing if they were needed. And interestingly, they felt from their perspective it was easier to save tissue than a tube of blood. And then in terms of the cost of genetic testing for someone who has passed away, that's also an important question clinically. And we know that typically a patient's insurance ends when they pass away. So insurance often does not pay for postmortem genetic testing, and that can be an issue when you're trying to find the cause of death in someone who's passed away. So we do talk about options with the family, whether they have the ability or means to self-pay for that testing, or there can be other options such as charity care, and some organizations actually provide limited funding for that type of testing.
And I can comment directly on the autopsy. So in academic medical centers especially, we routinely do save either dried blood spots, or we do occasionally save blood as well as frozen tissue. And that's pretty common in academic centers. And then in terms of hospital autopsies, if there is a compelling reason to do genetic testing, we do consider that on a case-by-case basis for that particular autopsy. And as most people may or may not know, the autopsy is the one thing in most hospitals that you can get for free. Of course, you have to pass away for that to happen. But so in that particular setting, the cost of genetic testing would be covered by the autopsy, but we don't do it routinely.
Thank you.
Okay, so our next case is related to a patient where direct-to-consumer genetic testing came to play with her clinical visit at the genetic medicine clinic. So this is another patient who has a family history of breast cancer. She is 47 years old, and her mother was diagnosed with breast cancer in her 60s and passed away at 72. She also had a sister who was diagnosed with breast cancer in her 30s and passed away at 42. Her family history, as you can see, the ancestry on her maternal side is Finnish and Swedish, and paternal side is Irish and Norwegian, and that will be important later in the case. So this patient, based on her family history of breast cancer and the increased risk for her, had had a mammogram, which was normal, and she also did retain her uterus and ovaries at the time that she visited the clinic. So based on the family history, genetic testing was sent for this patient, and it was a few years ago. So again, this was BRCA 1 and 2 genetic testing that included sequencing and deletion duplication of these genes. And she was actually found to have a pathogenic variant in the BRCA2 gene. So as Dr. Hisama mentioned, pathogenic variants in this gene increase the risk of breast cancer up to 84% by age 70, as well as increase the risk of ovarian cancer up to 27% by age 70. And so for management of this patient, she was referred to a prevention program for breast and ovarian cancer at another local institution. And she did have a preventative oophorectomy soon after that visit, and was set up with a schedule of screening for breast MRIs and mammograms, and was considering a prophylactic mastectomy. So about a year later, the genetic counselor who had met with this patient received an email thanking the genetic counselor for the work that she had done with the patient and for helping her through the process. And then she mentions that recently she did the 23andMe genetic testing after her generous boss gifted this to her for her birthday. And she mentions that the results of this 23andMe testing came back indicating that she has a lower than average chance of breast cancer, and that she did not test positive for pathogenic variants in either of the BRCA2 genes. She noted that 23andMe does mention that the test isn't exhaustive for all BRCA variants, But she felt that this information disclosure could have been easily overlooked or dismissed by other individuals who hadn't had the kind of exposure to genetics that she had had. And then she says that if she had not done the genetic test with the genetic counselor, she thinks she may have received those results from 23andMe and felt reassured and not move forward with clinical genetics, especially given the cost involved and the cost difference. So she asked the counselor that when she has a moment, if she can explain why the Myriad test or the clinical genetic test came back positive and the 23andMe was negative. So these are the results from this patient's 23andMe testing, and you can see in the top box that the breast cancer risk here is indicated to be below the average risk, and the ovarian cancer risk for this patient is reported to be typical. And then the bottom box, we can see the 3 Ashkenazi Jewish founder variants that were tested for in this patient. And these were all negative, but as you remember, this patient does not have Ashkenazi Jewish ancestry, so we would not expect those to be positive, and this isn't really an indicated test for this patient. And I think this case brings up a few of the different challenges that we see in the clinic with direct-to-consumer genetic testing. One is potential misunderstanding on for the patient, where we can see that there is the potential for false reassurance when results are returned, that the patient may not understand what actually was tested for. And then also the potential burden for the clinical providers in the genetics clinic to work with patients who are looking for interpretation of these results when they may not have been fully informed before the test was done or confused when they receive the test results.
And I do not have any questions from our audience for the direct-to-consumer portion of the slides, but I do want to encourage the folks that are newer attendees to be asking questions and using that Q&A box in the bottom left-hand corner of your screen. We're happy to field questions that are related to these cases that we're presenting, but also if you've had experiences in your primary care practice or other practice that you'd like to run by some of our experts, feel free to do so.
And I will also mention before we move on, when we think about these types of direct-to-consumer genetic tests and what to do with the results, we actually do have a policy in our clinic where we don't see patients being referred for interpretation of their direct-to-consumer genetic testing because presumably that testing may not have been done for a medical indication, and if the patient does have a medical reason to come to the genetics clinic, we would like to see them for that concern.
Okay. So I'd like to talk a little bit about a case that I saw when I was a medical student in my primary care rotations. So the patient was a 37-year-old woman of Indian descent, and she came in for just a routine prenatal checkup. And the practice in the clinic I was in was to offer carrier screening for a multitude of different diseases, including cystic fibrosis. And we allowed the patients to opt in or out of those particular carrier screenings. And this patient, even though she had no family history, she was interested in pursuing cystic fibrosis carrier testing. So at that time, we took a sample of blood and we sent it to the laboratory for a panel of 23 different mutations for cystic fibrosis. And the result came back negative several weeks later. And the patient, when she received the results, was very interested. And she said, well, great, but how good is this test at detecting CFTR or mutations in this gene in people like me, people of my descent? And so we discussed it, and some of the answers we thought of are listed here. So it could be equivalent in all different ethnicities. It could be an increased detection rate, so the testing could be more tuned to pick up variants in this particular ethnicity. It could also be decreased in this particular ethnicity, or we may not just have enough information. And so looking at the data, what we see is that there are different detection rates in different ethnicities. And so the Ashkenazi Jewish population has been very well studied. And so the particular 23 mutation panel that was used is most sensitive in that population. And so you can see before the testing, the carrier risk is 1 in 24. And then with a negative result, the carrier risk goes to 1 in 380. And if we look at the different populations, so non-Hispanic whites, it's similar. But then we go into Hispanics or African Americans or Asian Americans, and what we see is that detection rate drops precipitously. And so even though the carrier risk before testing is a little bit lower than in the Caucasian population, it doesn't reduce the risk as much with a negative result. So our patient asked a very appropriate question. So over the last several years, many different laboratories and commercial companies have instituted different panels for cystic fibrosis screening testing. And here are a couple examples. So we've gone to situations where there are hundreds of individual mutations that are tested in a variety of specific sites. And so a recent publication looked at exome data in the Exome Aggregation Consortium, or EXAC. And this is a database of 60,000 individuals from a variety of different scientific studies, not selected for cystic fibrosis mutation status, but that information was captured. And so what this particular study did was look at these different commercial panels and say, what is the carrier frequency we detect in the 60,000 exomes that we have? And what you see is the panels, by and large, they do a little bit better than the 23 mutation testing that's recommended by these organizations, but they do a little bit differently. If we look to the far right of the graph, if we looked at the East Asians, some of the particular tests do much better and others do about the same. So in addition to expanded panel testing, there is option to do entire gene sequencing of the cystic fibrosis gene. And so what we see here is a study looking at that particular test in different populations. And what we see is the detection rate is much, much better in all the different ethnicities. And similarly, after the testing, we get a higher confidence that a negative result truly means the patient is negative for carrier status.
Thank you, Dr. Konnick. I have a couple questions. Lots of people are putting questions in now, but a couple related to cystic fibrosis testing. One of our attendees asks, do you think the current panel, which I assume they're referring to our 23 mutation panel, reflects the diversity of the American population? And then I would add to that, what do you think are some of the pros or cons of automatically offering one of those larger panels that you mentioned?
No, it's a very good question. And so I think these data definitely speak to the fact that the 23 mutation panel does not represent the diversity we currently see in the United States, let alone worldwide. And so it does make sense to consider these broader panels for certain ethnicities. The caveat is that not all the mutations that are going to be detected have been well studied. So those 23 mutations have been well vetted. We know that those are associated with cystic fibrosis. Many of these other mutations in these expanded panels or in whole gene sequencing, we may not have that same information. And so the risk is that the results that are returned may be a variant of uncertain significance. And that can put the physician or the practitioner in a difficult situation talking with the patient about what their risk actually is, because we just don't know and the data aren't there. So that's the downside of using expanded testing.
Thank you. And then I have lots more questions coming back for you, Laura, related to some of the direct-to-consumer testing options.
Great.
Let's see. One person asks, as we're getting results back from direct-to-consumer testing, I'm assuming in their practice, would those results be considered confidential and HIPAA compliant? Would those go in the medical records, or do those get shared with insurance companies?
Yeah, so I think that is something that may be less defined, and so it's a really good question. It seems like if it's information that the patient brings to you in a care setting, it's something you talk about regarding their medical care, that information would go into the medical record, and then as we know, information that's in the medical record is accessible to insurance companies. But because it is testing that's done without a provider being involved in the ordering or that initial interpretation, you can see a context where it doesn't become part of the electronic record or the medical history of that patient and potential complications with that.
Yeah. And then another question that I think is probably relevant for a lot of our folks that work in primary care settings, but they ask to you specifically if you can comment on where we are right now in being able to, in the context of carrying out direct-to-consumer testing for healthy patients that are walking in the door to these primary care settings. So where are we right now? What are the pros and cons of what's out there and being offered?
Yeah, I think one of the challenges with what's being offered is how it's being marketed in a way that it seems to consumers as a medical test, where the information that's provided is related to ancestry or other non-medical traits. So I think that that's, part of the information that we get that is more maybe validated, like the ancestry information, and what we get on the medical side is more challenging. There has been research on if we send tests to different companies, are the results the same for the same individual? And there is discordance in those results based on the different SNPs or the different genotypes that are being looked at by the different labs. So I think there's some challenge in the validity of that, those results related to medical conditions. And then lastly, I'll just mention there has been a lot of research in the last few years looking at outcomes from direct-to-consumer testing, where it doesn't seem that there has been significant harm being done to individuals who are having the testing, so like in a psychological way. But it's really hard to quantify the benefits for those individuals as well. And we know that that testing is being done by a self-selected population of individuals who are treatment seekers and who may be trying to answer a medical question. So how that would play out as direct-to-consumer testing increases across the population will be interesting to see.
So I think it's important to realize if you have direct-to-consumer testing that the disclosure that comes with it is that this is not for medical purposes. It's for information purposes. So it's not a substitute for a real genetic evaluation in a real genetics clinic with a real genetics provider. We do see, and we get questions quite often from people about their direct-to-consumer testing. And again, our recommendation is not to treat people based on those results, not to diagnose people based on those results, but to have an actual clinical evaluation. We typically see that although it's marketed as being for information purposes, we do see patients who come and they're trying to diagnose themselves through direct-to-consumer genetic testing. And we think that that is not a good idea. And that harm can come from direct-to-consumer testing, like the example that Laura gave, where the patient clearly said if she had not had a visit to a genetics clinic and clinical genetic testing, she might have thought that her own risk of breast cancer was low. Okay.
Mm-hmm. I had another breast cancer question come up, Dr. Hisama, that maybe you can speak to. This provider, I assume, has a 50-year-old patient who has been up to date on her routine screening. Everything has been coming back normal. But her mother passed away from triple-negative breast cancer that was first diagnosed when she was only 38 years old. The patient did move forward with BRCA1 and 2 testing, which was normal, but the provider is wondering what to do. Should they keep continuing just with the routine screening as they have been, or should they recommend additional testing to their patient?
Right. So that's a good question, and this certainly does come up because of the expanded panels of breast cancer testing that are now available. So in a situation like that, what we would recommend is actually the patient come back to a genetics clinic or consider updated genetic evaluation if it's been several years. I can give you an example of a woman that I saw whose mother had ovarian cancer, and the mother with ovarian cancer, who was the appropriate person to test, had negative BRCA 1 and 2 genetic testing. However, as testing improved over several years, she went back to the genetics provider, and she had additional testing, and she was found to have a mutation in another ovarian cancer gene more recently discovered called RAD51C. So then my patient, who's the daughter, who is cancer-free, was tested for that, and she was positive for that mutation. So again, testing limited to BRCA1 and 2 in this family would have been uninformative.
Thank you. I think we can move forward with the next case, and I'll keep taking questions as they come.
Thanks, Lauren. So our next case is related to familial aortic aneurysm. So this was a patient who came to clinic. He was 64 years old when he came, and he had a history of an abdominal aortic aneurysm a few years before. And you can see from the pedigree that his mother had also had an abdominal aortic aneurysm, as well as his maternal aunt. So it appeared that there was a pattern, potentially a dominant pattern in the family, and potentially an increased risk for vascular complications or problems in this individual. So what is the rationale for evaluating this individual for a genetic risk for aneurysms? The first is trying to identify a diagnosis to define the risks. So thinking about, is there an increased risk for additional aortic or extra aortic aneurysms, dissections, or ruptures? And then could there be other non-vascular issues for this patient to consider? Secondly, thinking about management or prognosis. So for this patient, genetic testing could inform how extensive and how frequently to do vascular surveillance. And if surgery is something the patient is thinking of, when to intervene. Could this be an aneurysm that would progress more quickly than another aneurysm that does not have a genetic basis? And then what to expect with surgery. Could there be a difference in the tissues of this individual based on a genetic change? And then for some aneurysm conditions that have a genetic basis, specific medications have been recommended and are currently being evaluated that have been shown to be beneficial for this population, for example, losartan or a beta blocker. And then finally, looking beyond the patient to family members, if a genetic cause is identified for this patient, then family members who are at risk to carry the same pathogenic variant could be tested specifically for that change, and those that do have the same pathogenic variant and thus have an increased risk could be screened based on that information. And then those who haven't inherited that variant could not have screening because we know that they would have the baseline risk for aneurysms, and that could, save them costly and potentially invasive procedures in the future. So this patient had a genetic test for 6 vascular aneurysm genes, and they're listed here, and his results were normal. So the recommendations for this patient were to follow up in clinic in 1 to 2 years, because we don't know all of the genes that could be associated or are associated with an increased risk for vascular abnormalities. So it's possible we could identify a new gene in the next few years. Also, it's possible there could be something in the genes that were sequenced that was missed, so potentially a new type of technology that could be developed may be applicable to test those genes again in the future. We don't recommend testing for other family members in this family because a genetic cause wasn't found. And then finally, that this patient should continue with screening based on the personal and family history, because it does still appear that there's something going on where there's an increased risk for this person.
Great. I have one question here from one of our attendees speaking to that, and the question being, for a family like this where we're strongly suspecting a genetic etiology, should we pursue additional testing like whole exome sequencing, and kind of where do you draw the line where that becomes a benefit?
Yeah, that's a great question, and I don't think that we have the data for conditions like this at this time. Most of the known genes that are associated with an increased risk for vascular problems would be tested for on a panel, so it's not clear what if any, increased yield there would be by doing exome sequencing. So I don't think that it's something at this time that would make sense for a family like this. Maybe in a few years, there could be potential benefits of that. If an exome is done, then you could, re-look at the exome in a few years, so you don't have to have an additional genetic test done. However, cons could be insurance coverage for an exome for this indication is probably not going to be feasible, so cost. And then also with exome sequencing, there is the potential for incidental findings. So that might be something that is something to talk about with the patient and might be a consideration.
And another question about this case, but maybe for Dr. Hisama, why bother testing these genes at all on this vascular panel? What if that doesn't change management? How is that going to help either that patient or their family?
So there's two ways to look at this. So one is the diagnostic implication, so that you can say what the cause is for this patient and for this family. Oftentimes, really, the cost effectiveness or the utility of the testing comes into play when we start testing other family members. Because if other family members are having frequent expensive screening, like echocardiograms, if they did not inherit the known genetic risk factor in their family, they can stop screening. So you can really target interventions at people who need it. And the other point here is that conditions like aortic aneurysm can be fatal. So again, what we want to do is identify the people who are at risk and institute screening and prevention for that individual, for those affected individuals or at-risk individuals.
And then before we go on to the next case, we have one of our attendees asking an unrelated question, which we welcome. Feel free to submit them. And this is, do you have any comments on what testing these providers should be doing for someone with habitual abortions or having stillborns without dysmorphic changes? Should they be testing on products of conception? Kind of what are the guidelines and what are your recommendations along those lines?
So I think it depends, first of all, on the history, the pregnancy history. Have they had any successful pregnancies? At what stage in the pregnancy have they had the pregnancy losses? So it sounds like there may be some early losses as well as stillborns in this case. Usually genetic testing is not done after 1 or 2 pregnancy losses. But again, for the if there are 3 or more, then typically people do genetic evaluation, and it can start with either just chromosome analysis or microarray on the products of conception. And again, this would depend on the stage. Personally, I've gone down to the autopsy room and done examinations of pregnancy losses or stillbirths to try to identify a genetic condition, in the affected individual.
Thank you. And did you have something to add?
I was just going to add also an evaluation of the parents to see if there's any kind of like a translocation that one of the parents carries or some kind of clotting condition in the mother. I think that those are baseline tests that may have already been run, but something to consider.
Great. And then a question that came through also, kind of an off-the-wall question, but I think an interesting one, is do you have any tests that your patients regret having? Or is there one test in particular that they come back saying that I wish that I hadn't had that test? And can you speak to that?
I think that there are conditions where we have a heightened concern that there could be regret, and that those conditions often fall into the category where there isn't any change to medical management or treatment. For example, with Huntington's disease, where it's a condition where it's a neurodegenerative condition, there's nothing we can do about it. It's 100% penetrant if you have a certain number of repeats in the gene and live to a certain age. So we do have a protocol at the genetics clinic where we meet with them for counseling. They visit with a neurologist, and then we have post-test counseling and return of results in person to try and help people think through the process and think through what they would do with a positive or a negative result to try and mitigate that regret. And I think that's one of the goals of genetic counseling, is so people make informed decisions. But there's no way we can know the future and know if people maybe they don't regret it right when they get the result, but maybe 10 years down the line they might feel differently. But all we can do is share all of the information we have and support people through that process.
great. Thank you.
Yeah. So switching gears a little bit, so this particular patient was a 5-year-old Asian American child. She had her tonsils out for obstructive sleep apnea, and the physician prescribed Tylenol 3, which is acetaminophen and codeine, for her pain management. And so the parents were very good, and they administered exactly the dose that was recommended, and they kept a very close eye on her. And what they noticed was relatively quick after the dosing of medication, she started to breathe shallowly. She also seemed more lethargic than they would have expected. And then when they looked at her eyes, they noticed that she had pinpoint pupils, and she seemed more confused than they expected. And so, being very concerned, they discontinued the medication, watched her very closely, and luckily she recovered. So when they came to clinic, the parents were still concerned about this particular interaction and seemed to think that the drug had something to do with it. And they wanted genetic testing. They thought that this had some genetic basis, and so they come to you and they ask, what would you do? And so would you reassure the parents that the reaction's idiosyncratic, there's nothing that they can do, they observed her closely, and that's good enough? Would you recommend cytochrome P450 genetic testing, whole genome testing and analysis, or mitochondrial DNA mutation analysis?
Okay. We'll just give you a second to think about that.
And in this particular case, to answer the question of the parents, cytochrome P450 testing is the best answer. So if we look at the metabolic pathway of codeine, what we notice is that the CYP2D6 enzyme is integral in the conversion of the prodrug codeine to the active drug morphine, and also from hydrocodone, which is another metabolite of codeine, to hydromorphone. And so what we know about the metabolism of codeine to morphine is that there are different phenotypes that can be observed. So there are ultra-rapid metabolizers, and these individuals show an increased conversion of the prodrug to the active drug. We also know that there are poor metabolizers, people who don't seem to have an analgesic effect, and the reason is because their body can't convert the codeine to the active morphine. So looking a little bit further at these phenotypes, the underlying reason for this is that there are some different characteristics. So the enzyme itself can have low activity or no activity, or have normal activity, or there can also be increases in gene copies. So depending on the combination of the enzyme activity plus the number of copies of a particular gene, you can classify people into different metabolic categories. So from poor metabolizers who have low or absent activity and a normal number of gene copies, to people who have a normal phenotype in terms of enzyme activity but have increased numbers of genes, and so they show what's seen as an ultra-rapid metabolism. So the other thing to know about the CYP2D6 enzyme is that it's involved in the metabolism of roughly a quarter of all drugs. There are greater than 75 variants that have been identified. And again, in the situation of codeine, people who are poor metabolizers have a poor analgesic response because of reduced conversion of codeine to morphine, and then ultra-rapid metabolizers have the opposite effect, where they have too much of the morphine on board, and then they can have increased response, or the situation that we saw in this particular child. Again, similar to the cystic fibrosis case, what we see here is, depending on the ethnicity, we have different metabolizer phenotypes. And so what we see is in people of Asian descent, up to 20% of the specific population can actually be an ultra-rapid metabolizer, whereas within the Caucasian population, roughly 1% to 5% of individuals would have that particular phenotype. So this particular individual, laboratory testing was sent off, and the result came back as a CYP2D6 star2X4. And what does this mean? And so it means that the star2 allele has normal enzyme activity, but the X4 means that there's actually 4 copies of the gene present. And so the interpretation of that is that for this particular individual, they fit with an ultra-rapid metabolizer phenotype. And so the implications for this individual are for codeine is not a drug that they would recommend using on this particular patient. And actually, the FDA has a black box warning on this particular drug for exactly this indication. And the reason for that is that over the past 40 years or so, approximately a dozen children have died from this particular reason. And so definitely good to know. At the same time, they don't recommend routine CYP2D6 testing for people being considered for codeine dosing. And the other thing to know is that there are approximately 25 other drugs on the FDA's list where they indicate that the metabolic activity of CYP2D6 impacts the effectiveness of a particular drug. But for all of those drugs, they don't recommend testing for this particular enzyme. So coming back to our patient, we know that in this particular case it had an effect on that person, but we also have to consider implications for the parents and the siblings, which is definitely important in a primary care setting.
Thank you. And I have two questions coming in from our attendees about this topic. One about cost. Did insurance cover the cost of this pharmacogenomic test? And another's, and you can answer that first, and I'll give you the other.
So in this particular case, my recollection is the insurance was good enough that it covered it, but that's not going to be the case in all situations. Of the spectrum of different types of testing, this is on the relatively affordable side of things, so probably several $100s would be the cost of testing. But I could anticipate in situations where it would not be covered.
Thank you. And then another question asking, in the presence of a clinical reaction to the medication, how does it really help to classify the metabolism mechanism?
Right, and in this particular case, there wasn't really any reason to go down that diagnostic pathway. It was more interest of the parents and persistence on their part, and so that's the reason why. And also just given the time frame and things like that, the particular deaths that have been associated with this particular reaction, there was a heightened interest.
But it also gives information regarding potentially prescribing other drugs that in the future, right, that are also metabolized by the same enzyme.
And then someone asks, if this test is affordable, why do we recommend against this as a routine test, was how they phrased it.
So it's not, I wouldn't say it's necessarily recommended against, it's not endorsed as a requirement for prescribing a vast majority of medications. So the FDA has very specific indications for a variety of different drugs for metabolic enzyme activity or other biomarkers around the use of that particular drug. And for a variety of reasons, they just haven't come down and said for, delivering class of drugs X, this is a prerequisite before you dose the drug.
Thank you.
Okay, so the next case is also a pharmacogenetic case. This is a 12-year-old boy of Chinese ancestry who has epilepsy and has been taking carbamazepine for his complex partial seizure disorder. His epilepsy is well controlled on the medication and he's on a stable dose. His mother comes to the clinic and says that she's heard that there's a genetic test to predict if he will have a side effect from the medication, and she wanted to hear more about that. So it's important to recognize that carbamazepine can have very serious, life-threatening, even fatal side effects, particularly from a toxic epidermal necrolysis or Stevens-Johnson syndrome, where basically there's this horrible rash appears, the skin can slough, and obviously it can be like a burn. The prevalence of this disorder is about 1 to 6 in 10,000 people of European ancestry. And there actually is an FDA alert about this particular medication, which came out in 2007. So basically, this alert said that Stevens-Johnson syndrome or toxic epidermal necrolysis can be caused by carbamazepine treatment, and it's more common in patients who have a particular human leukocyte antigen allele called HLA-B1502. And the FDA went on to say that this particular allele is more common in people with ancestry across broad regions of Asia, including South Asian Indian ancestry, and that genetic testing for this allele is clinically available. And in this case, they actually recommended that people with ancestry from these geographic areas be screened for the allele prior to starting treatment with carbamazepine, and that if they tested positive, meaning they have the 1502 allele, that the risks and benefits of treatment with carbamazepine should be considered before starting treatment. So a little bit more about the HLA-B1502 allele. So it's known to be present at a significant percentage of the population in the Han Chinese, in the Malaysian, and the Thai population. However, it's present in less than 1% of the Japanese, Korean, and Sri Lankan population, and in approximately 1 to 2% of Northern Europeans' background. So there have been several papers which actually tested the hypothesis that genetic testing for the HLA-B1502 allele would reduce the risk of side effects from starting carbamazepine. And this is a study that came out in 2011 in which they instituted widespread screening in Taiwan prior to starting carbamazepine. And so they used historical data for a baseline, and indeed, when people were positive for the 1502 allele and were advised not to take carbamazepine when they presented to clinics, then the risk of Stevens-Johnson syndrome dramatically decreased. Okay. Another paper came out a few years later which looked at carbamazepine-induced hypersensitivity in 3 European populations, and they found a different allele, which is HLA-A3101. Okay. And that same year, in 2013, there was actually another paper in Human Molecular Genetics which found the HLA-A3101 allele was the genetic risk factor for carbamazepine hypersensitivity in the Japanese population. So I brought up this case really to highlight some of the hazards of ethnic-based pharmacogenetic screening. In other words, prescribing based on someone's reported ancestry. So here's the problem. So again, the FDA recommendation was that persons from a geographic region of Asia, which they define rather vaguely, should have genetic testing for the HLA-B1502 allele. But again, notice that in the Japanese, Koreans, and Sri Lankans, that is actually a very rare allele, whereas the HLA-A3101 allele is actually the most prevalent allele that causes carbamazepine hypersensitivity in Northern Europeans, but also in a significant proportion, it's the most common allele in the Japanese population and is also present in the Han Chinese population. Okay. So to go back to the FDA alert, notice that they also say toward the end of the alert that patients who have been taking carbamazepine for more than a few months without developing skin reactions are at low risk of these events ever developing. And this is true for patients of any ethnicity or genotype, including patients who are positive for HLA-B1502. And remember, this patient had actually been taking carbamazepine, had a good therapeutic response in terms of epilepsy control from it, and had been on the medication for 2 years. So therefore, in this particular situation, even though he's of Chinese ancestry, there's not an indication for genetic testing to predict his risk to develop a side effect from being on it, because he's already basically had the test and has passed it. Okay.
Great. I have a general question here related to pharmacogenetics in general. As this type of testing becomes more routine, who should these providers be going to consult with as they're trying to understand the implications of these results?
Right. So interestingly, this particular set of genetic questions does not come to the genetics clinic so often. So I think that in terms of implementation, it tends to be implemented more by the prescribing providers. So in other words, you as a neurologist prescribe anti-epileptic medication, so then you become familiar with a small set of genetic tests that are relevant to, for example, prescribing epilepsy medications. Similarly, oncologists are becoming familiar with genetic testing that guides precision treatment of cancers and so on. We'd be happy to see these patients in the genetics clinic, but again, this seems to be more a point of care kind of genetic test that's more specific around prescribing.
Go ahead.
Oh, I just said I would also mention pharmacists as a potential resource to connect with, and then also the laboratory that did the testing. Excuse me, they might have some support and some information about interpreting the significance of the result.
Mm-hmm. I know in some situations there's been discussion about using the electronic medical record for really high-risk types of situations. So, for example, carbamazepine. And so, that's something in terms of organizational level, using the knowledge and expertise of the pharmacists, of your geneticists, of your laboratory, to discuss, what are the things that are really high impact that we do not want to miss on any basis at all. And so I know there have been pilot trials in different hospitals, including here, for alerts and things like that. So that's an option as well.
I also just want to mention briefly a very good resource for pharmacogenetics, which is a website. So if you search for PHARM, P-H-A-R-M, GKB, then that has a lot of very useful information on specific pharmacogenetics that you can search either by drug or by the genotype.
And then I have an additional question that just came in. For the Chinese boys' non-sensitivity to this medication, does that argue against testing other family members for the HLA-B 1502 who would have otherwise been recommended to have testing?
I probably would not go by that solely, and I probably would offer them testing.
So just a comment on the genetic testing. So typically for these types of very specific indications, so HLA-B27 and ankylosing spondylitis, or again, this situation where you're looking at a very specific genotype, the way the laboratory typically does this is they only look at that nucleotide change. They don't look at all the other nucleotides or the rest of the haplotype. And so with HLA especially, we have situations where this may be the genetic change in that individual, but there may be a mutation that makes it so it isn't expressed, a so-called null allele. And so you can't get that information from the vast majority of this type of testing. So again, kind of speaking to the fact that this individual may have inherited something that makes them not susceptible, but their sibling or parent could have an active form that would make them susceptible.
Thank you. Oh, and I was going to add that the website that Dr. Hisama just mentioned will be available in the toolkit so that you'll be able to access that as well.
So the next case is a healthy 50-year-old woman who recently moved to the area and established care with a new primary care provider. And her family history was taken, and she's concerned about her family history of Alzheimer's disease and asked whether there's genetic testing to predict whether she will develop it in the future. She's currently working full-time as an attorney and has no concerns about her memory. So when someone comes to ask about Alzheimer's disease, then of course I ask why they're concerned about it. Are they themselves concerned that they have early symptoms of it or not? So again, this is a non-concerning family history. If this were her family history, her mother had Alzheimer's disease diagnosed at age 75, and she passed away from the disease at age 80, and there's no one else in the family with a history of Alzheimer's disease. So this family history is more typical of sporadic Alzheimer's disease and not suggestive of a strongly inherited form of Alzheimer's disease. So this would be so-called sporadic Alzheimer's disease, such as President Reagan had, and this is, of course, a very common age-related neurodegenerative disorder that affects memory and cognition. It's very, very common in the population. 10% of people over the age of 65 have dementia, with the most common cause being Alzheimer's disease, and up to 50% of people over the age of 85 have dementia. Again, the most common cause is Alzheimer's disease, and the second most common cause is vascular dementia. We know that Alzheimer's disease currently affects over 5 million people in the United States, and this is predicted to increase by about 50% by the year 2025. And again, for sporadic Alzheimer's disease, this is known to be a complex trait, meaning that there are multiple genes involved as well as environmental components. So the strongest genetic risk factor that's known for sporadic Alzheimer's disease or late onset Alzheimer's disease is genetic variation in a gene called apolipoprotein E. So we all have this gene, and there are 3 alternative varieties of it, or alleles, called E2, E3, or E4. So an individual's genotype can be one of the following combinations because, again, each individual inherits 1 copy of ApoE from his or her mother and a 2nd copy from his or her father. So we know that the most common allele in the population is E3, and we know that the E4 allele increases the risk of Alzheimer's disease and lowers the age of onset for sporadic Alzheimer's disease, whereas the E2 ApoE allele is protective against Alzheimer's disease. So in other words, the individual at lowest risk would have E2E2, and the individual genetically at highest risk would have E4E4. Okay. So what about predictive genetic testing for sporadic Alzheimer's disease, which is the situation that the attorney in the scenario came to the clinic with? So predictive genetic testing in general is genetic testing in a healthy person that is to predict their risk of having a specific disease in the future. And of course, we do this routinely in the genetics clinic for preventable diseases such as colon cancer or breast cancer. However, Alzheimer's disease is different because there currently is no preventative treatment for Alzheimer's disease. And we also know that ApoE genotyping is not that good at prediction for Alzheimer's disease. And so it's a current practice guideline of the American Academy of Neurology that ApoE genotyping is not recommended to predict risk of Alzheimer's disease in a healthy person. Also remember that ApoE4 is a risk factor for Alzheimer's disease. So ApoE4 by itself does not determine whether a person will develop Alzheimer's disease. So I look at a risk factor as being similar to, say, for example, wearing a seatbelt or smoking. Not wearing a seatbelt is a risk factor for injury in a motor vehicle accident. Smoking is a risk factor for lung cancer and many other diseases. But of course, smoking is not a guarantee that you'll develop lung cancer because many people who smoke do not. However, unlike environmental modifiable risk factors, genotype cannot be changed. And individuals who are even at the highest genetic risk, who have the E4 genotype, still may never develop Alzheimer's disease, which again limits its usefulness in predictive genetic testing. In contrast, about 5% of Alzheimer's disease is what we would call early onset familial Alzheimer's disease, and this is inherited as a Mendelian autosomal dominant trait, usually with onset before the age of 65. And for early onset familial Alzheimer's disease, it is strongly genetic with a penetrance approaching 100%, and so a person who is affected has a 50% risk to pass it on to each of his or her children. Someone who did not inherit the disease allele is not at risk. It stops there, and he or she cannot have passed it on to children. So what about the situation for testing and prediction for early onset familial Alzheimer's disease in contrast to the late onset sporadic Alzheimer's disease? So if you saw the movie Still Alice, then this situation is actually portrayed in the movie. And in the neurologist's office, then she's advised actually to go to a genetics clinic for pretest counseling. And so the distinction here is that in contrast to ApoE genetic testing, which is a risk factor, a positive genetic test in, for example, presenilin 1 is predictive that that person who has that pathogenic variant will develop Alzheimer's disease. So again, to make a distinction, diagnostic testing is to help diagnose someone who has Alzheimer's disease as to what the cause in them is and to provide information for family. Predictive testing is doing genetic testing in someone who is healthy and unaffected to say will they develop Alzheimer's disease at some point in the future? And so, of course, that particular scenario is very highly emotionally charged. And so we recommend that this type of specialized genetic testing not be done in a primary care setting, but be referred to a specialty neurogenetics clinic, typically in an academic center, and that this type of testing really does require careful pre-test counseling. Some patients at that point, as was brought up a little bit earlier, would decline to go forward with testing at that time until they're emotionally, financially ready, have prepared their family and all that sort of thing, as well as post-test genetic counseling and support for the results.
We have two questions, Dr. Hisama, that have come through so far. The first relates to medical management for a patient that does test positive for one of these predictive Alzheimer's genes. Is there anything you'd recommend that they change? And if not, how likely is it that insurance is going to come forward to pay for a test like that?
So the first question was what kind of medical management? Mm-hmm. So one of the difficulties of predictive testing is that we can say if someone tests positive for a presenilin-1 pathogenic variant that they will develop Alzheimer's disease. We cannot say when they will develop Alzheimer's disease, of course. And so, of course, it's part of the pre-test counseling to make sure that they understand that. We know that in families who are at risk for either early onset familial Alzheimer's disease or Huntington's disease, which is a similar scenario in terms of genetic counseling, that there's a wide range of age of onset even within a family. So what we recommend that people do obviously is really put some thought into how they will, live with the results. Obviously, we want to make sure that people have support in terms of continuing with their career, their life, making sure they've made appropriate financial arrangements, considered power of attorney, those types of issues. But basically, again, there's nothing that we can do to prevent the onset of Alzheimer's disease. But for sporadic Alzheimer's disease, there certainly are risk factors. For example, we want people to control their blood pressure, treat diabetes. We know that exercise is very good for prevention of dementia, continuing to be, both physically and mentally active, that type of thing.
And so then that second part fell into, if we can't argue to insurances that medical management will significantly change, what's the likelihood of that testing being covered?
I think for a lot of insurance, if it is a familial condition where there's a known pathogenic variant in the family, then that is something that is commonly covered by insurance. But I think that is correct, that's the number one evidence that insurance wants to justify genetic testing is medical management. I think one of the things that we say is to argue with insurance is if we know, a diagnosis, it could potentially decrease any evaluations done trying to identify the cause of symptoms a person could be having. That would probably be more challenging in an individual who is clearly not symptomatic. But that's one of the things that we have, that we use. Clearly for us, the value of a diagnosis and information for family members is one of the things we take into consideration, but that doesn't commonly come into play for insurance companies.
And then another listener asked, what's the effectiveness of treatment for someone with the E4 genotype? So some of those recommendations that you mentioned to reduce those risks, how effective would that be in that population?
Yes. So of course, like healthy lifestyle and things and so on do not hurt, right? So you're always talking about risk-benefit ratio. I'm not sure that we've actually proven quantitatively how much it reduces the risk, although I just saw an article like last week that people who actually have the E4 genotype and eat fish at least once a week have like less risk of going from mild cognitive impairment to actual dementia. So Mediterranean diet is good for you.
Thank you. And before we launch into the next case, I'll just mention that we have just 8 minutes left.
Okay.
And so we'll try to go through as many questions as we can, and we'll get through one more case.
Okay. So this is the last case, and this is a 52-year-old man who came to the genetics clinic because his mother was diagnosed with hemochromatosis. And when I asked him, he was actually uncertain how his mother was diagnosed, but he reports that she was being treated for cancer at the time. So presumably she had some blood work that indicated she could potentially have this condition, and was tested and confirmed in her. So the patient had a serum ferritin which was greater than 500 nanograms per milliliter, so very elevated, because the normal range is between 18 to 270. He had additional iron studies which showed he had an elevated transferrin saturation, elevated serum iron, and then he had genetic testing of the HFE gene, which causes hemochromatosis, and he was homozygous, so he had 2 copies of a common disease-causing allele called C282Y. So hemochromatosis is a very, very common genetic disorder in the population. It's inherited as an autosomal recessive disorder. Clinically, some of the features are nonspecific and include joint pain, bronzing of the skin, diabetes, cardiomyopathy, and in later stages, congestive heart failure and liver cirrhosis. It's caused by mutations in the HFE gene, which actually result in more efficient or increased iron absorption from the small intestine. And 1 in 250 people of Northern European ancestry has 2 mutations and is at risk to develop hemochromatosis, and more than 10% of the population of European ancestry is a carrier for hemochromatosis. So this particular family pedigree was interesting because we have here an affected mother and an affected son. So this would appear to be dominant inheritance, but it's what we call pseudo-dominant because it's actually an autosomal recessive disorder that's manifesting in 2 generations in the family. So in other words, his mother is affected because each of her parents were carriers. She had to pass on 1 mutant allele to her son, my patient, and he received the other allele from his father, who's a carrier, but not known to be affected by hemochromatosis. So a key question in hemochromatosis is what percentage of individuals who are born at genetic risk actually develop the clinical manifestations of iron overload? The mainstay of treatment of this condition is called therapeutic phlebotomy, which is basically donating blood to reduce iron stores. In addition, there's some other medical recommendations such as taking extra iron in diet, like in the form of supplementation from iron-containing multivitamins, and avoiding excessive vitamin C or alcohol, which also increase iron absorption. So the basic concept here is that at birth, there's a cohort of individuals who are born with a genetic predisposition to have hemochromatosis. But what percentage of those individuals go on during their lifetime to develop the biochemical signs of hemochromatosis, the elevated iron, transferrin saturation, and so on, and how many of those individuals go on to develop clinical symptoms of iron overload with iron deposits in their liver, pancreas, heart, and so on, and that typically doesn't happen until their 50s or 60s at that stage of life. So there actually was a study that was published here from the University of Washington which evaluated the penetrance of hemochromatosis in a large HMO, and the study is called the Emerge Network. So they basically were able to mine the electronic medical record, and they combined that with whole exome data, and so they had the cohort of patients who are known to be homozygous for the mutation, and then they checked the medical record to see how many individuals had clinical evidence in terms of their ICD-9 codes for hemochromatosis. And so you can see here that fewer than 1/4 of the men who were genetically at risk developed clinical hemochromatosis. And for a different genotype, this compound heterozygous genotype, 97% of people did not have hemochromatosis, and only a very small percentage had clinical hemochromatosis. The numbers are smaller for women. Women are less at risk to develop clinical hemochromatosis. Probably it's been theorized because they lose iron every month through menstruation. So that is the last case.
Great.
And
Thank
I just
you.
want to thank everybody for their attention, and we'll be available in the network lounge right after this for further questions.
So
and
a couple more housekeeping items. Yes, there is the opportunity to get continuing education credits, and so there will be a CE button located, it sounds like in the lower left-hand corner of your screen, and so you can follow the prompts to obtain those credits. As well, I wanted to let everyone know that I'm told that this presentation will be available on demand for viewing, that you can let your colleagues know that this is out there, and you'll be getting an email from LabRoots letting you know of its availability. And then lastly, like Dr. Hisama said, we will be hanging out in what is called the networking lounge. If you go to the meeting lobby of your screen and enter the networking lounge, there's a live chat feature. And the 4 of us and our 3 presenters will be there to answer more questions. Unfortunately, the questions that we haven't had time to get through do not automatically get transferred to that section, but if you feel free to type in some additional questions and we'll try to field them in that setting as well. But thank you for joining us, and thank you to our presenters today. Okay.
still green, yeah.